I thank the organizers of the Pancreas Academy and my mentors at CAPA for this opportunity. This way, yeah. All right, and I'm a fellow at Johns Hopkins Hospital. I have special interest in pancreatic disorders, and I'm in a fellowship of the pancreatology also. And regarding the objectives, so we will be discussing the key concepts in the management of uncomplicated acute pancreatitis, some complications associated with acute pancreatitis, and some special situations involving pancreatitis. And in the 25 minutes, this is such a broad topic in the management of acute pancreatitis. So we will focus on the key concepts in the initial management, such as hydration, pain control, nutrition, and in the management of complications, we will focus on fluid collections, necrosis, and we will also manage management of some underlying and predisposing conditions. And regarding the initial management, fluid therapy is the cornerstone in the management of acute pancreatitis and the most effective treatment in acute pancreatitis. There are multiple factors involving the pathophysiology of acute pancreatitis, which will result in fluid loss, such as reduced oral intake, nausea, vomiting, and third spacing of fluids in the lungs and other tissue. And further, there are some inflammatory mediators and cytokines released during acute pancreatitis that can result in vasodilation and fluid leakage. So this will result in reduced blood supply to the pancreas, can result in cell death and pancreatic necrosis. So aggressive hydration is therefore important to improve the blood supply to the pancreas and reduce the risk of organ failure and pancreatic necrosis. And it is important to understand that fluid therapy does not fix capillary leak. And regarding the therapeutic window, so most of the fluid ideally works best when it is given during the first 12 to 24 hours. So it is important to give fluids while the patient is in the emergency room and not just wait till the patient comes to the floor. There are multiple studies that looked at the effects of fluid hydration on the effect of pancreatitis in the management of pancreatitis. And majority of the studies demonstrated improved outcome in the management of acute pancreatitis. But there are a few studies that showed increased risk of complications, such as the increased risk of pleural effusions, with all the fluid getting stuck in the lungs. But majority of these studies, they recruited more sick patients, so it could be more from reverse causation than from the fluid effect. But overall, the summary is that we should continue to use fluids in the management of acute pancreatitis and consider aggressive hydration. And now the question about what type of fluid to use, lactated ringer or normal saline. So multiple studies have compared lactated ringer and normal saline. And the key differences between the lactated ringer and normal saline is lactated ringer has lactate in it, which gets converted to bicarbonate in the liver and is thought to help acidosis in the setting of acute pancreatitis. And with normal saline, it has high amount of chloride. So this can result in hyperchloremic acidosis when given in large quantities. But recent studies have shown that lactated ringer does not change the pH, but rather inhibits the macrophages. So on the left panel, we see that between lactated ringer and normal saline, there is no significant difference in the pH changes. But rather, lactated ringer, it inhibits the macrophages. I'm trying to get the pointer here. Okay, so lactated ringer, it inhibits the activation of inflammatory types of macrophages. So that's the reason this may be the key mechanism by which lactated ringer might work better than normal saline. So we should consider using lactated ringer rather than normal saline. Multiple guidelines have recommended the regimens to be used in the management of acute pancreatitis. So they describe a volume for initial fluid administration and the volume for maintenance fluid. But the key concept is using a cold directed approach. So where we try to maintain adequate urine output, avoid tachycardia, and ensure adequate blood pressure, and maintain hematocrit in an appropriate range. Similarly, multiple randomized control trials have used different regimens of IV fluids. So they use aggressive or standard hydration, lactated ringer or normal saline, which I have summarized here in this table. But again, majority suggest using a cold directed approach while using IV fluids. And one key trial that I would focus on recently, So in this trial by Dr. Buxbaum and group, so they compared the use of aggressive hydration and standard hydration in the management of acute pancreatitis. And with aggressive hydration, they mean giving 20 ml per kilogram bolus fluids, then 3 ml per kilogram per hour continue maintaining fluids. And in the standard hydration arm, it is 10 ml per kilogram bolus, then followed by 1.5 ml per kilogram per hour maintenance fluids. And they noted clinical improvement to be much better when they use aggressive hydration. And by clinical improvement, they mean tolerating oral intake, improved pain symptoms, and improvement of creatinine and BUN. So aggressive hydration is recommended over standard hydration, but when we use a volume like this, it means around 6 liters of IV fluids in 24 hours, which could be a lot in many of the patients. So we should be using this judiciously. And next with the pain in the management. So abdominal pain is the predominant symptom among patients with acute pancreatitis. And there are some things involved in the pathophysiology of acute pancreatitis again, which result in hypovolemia and fluid losses that can cause visceral ischemia, which can also contribute to the pain in pancreatitis. Therefore, adequate fluid hydration is still important also for the management of the pain symptoms. And majority of the acute pancreatitis, if it's a mild episode, can be managed with non-opioid analgesics such as NSAIDs. And there is a good Cochrane review which showed that by comparing non-opioids and opioids, there was similar improvement in the pain symptoms at 2 days. And there were some prospective studies that showed that opioid analgesics increase GI dysmotility and delay oral feeding. Therefore, non-opioid analgesics should be considered over opioid analgesics. And if the pain is so severe and if we have to use an opioid analgesics, we can consider using oxycodone rather than morphine, because oxycodone has less effect on the centrally located mu opioid receptors, so therefore has less dependence and addiction. And there were some preclinical studies that showed that morphine can cause more severe pancreatitis, but that's still debated. And regarding the nutrition and reinitiation of oral feeding, so historically, it was recommended to keep patients on prolonged NPO status to give a rest to the pancreas to reduce the activation of the enzymes and inflammatory cascade, but there is no strong evidence recommending that concept. And rather, when patients are kept on prolonged NPO status, the gut mucosal barrier can be disrupted. So this will result in the transmigration of the gut flora, can increase the risk of infections. Therefore, early initiation of oral feeding is noted to reduce the risk of infectious complications and also overall morbidity and mortality. Therefore, in the absence of ileus, nausea and vomiting, and improved pain, so we recommend using oral feeding as early as within the first 24 hours. And regarding what type of diet should be used when initiating the oral feeding, it was shown that soft, low-fat, low-residue diet provides more calories when compared to clear liquid diet without increasing pain recurrence. So therefore, we should consider using low-fat, low-residue diet rather than clear liquid diet when initiating feeding. And now about the risk of readmissions. So there was a retrospective study that showed that 19% of the patients after acute pancreatitis can get readmitted within a median of 9 days. So that's 1 in 5 patients, which is pretty high. And they showed that the predictors for risk of readmission are GI symptoms at discharge, like pain, nausea, and vomiting. And the patients discharge anything on less than a solid diet, there is very high risk of readmission. So we should avoid discharging patients who cannot tolerate solid diet. And among patients who cannot tolerate solid diet, they need an alternate method for nutritional support, which can be non-oral enteral feeding, such as nasogastric or nasojejunal feeding, or TPN. And 12 randomized controlled trials compared TPN and NJ or NG tube feeding, and they showed that NG or NJ has lower length of stay, organ failure, and risk of pancreatic infections. Again, when patients are being kept on TPN and prolonged NPO status, this affects the gut mucosal barrier, increasing transmigration of the gut flora and pancreatic infections. Therefore, we should always consider using the gut and always consider using some form of enteral nutrition, even if it is a trickle feeding or small quantity of oral diet. And TPN is recommended only when enteral access is not available or if the patient is not meeting their caloric requirements. And when the question is, like, should we use nasogastric, which ends in the stomach? And so should we use a nasogastric tube, which ends in the stomach, or a nasojejunal tube, which goes much deeper? So historically, NJ tube was recommended over NG to give a rest to the pancreas by avoiding the gastric and duodenal stimulation. However, 4 randomized controlled trials compared NG and NJ. There was no difference in key clinical outcomes such as mortality, infectious complications, or length of hospital stay. There was some evidence suggesting that there is a lower risk of aspiration when we use NJ rather than an NG tube, but there are other studies which show that when we use standard aspiration precautions, then the risk of pneumonia from aspiration is still low. And NG is much easier to place, and we can avoid the use of endoscopic or IR guided placement, so NG tube is recommended over NJ tube access. And next, regarding the role of prophylactic antibiotics. So why this is important is because 20% of the patients with acute pancreatitis can have some form of extrapancreatic infections, including UTI, pneumonia, bloodstream infections, and there is 2-fold increase in mortality risk among patients with infected pancreatic necrosis compared to sterile pancreatic necrosis. But a Cochrane review of 10 randomized controlled trials showed no mortality benefit or reduction in the rate of infected pancreatic necrosis with prophylactic antibiotics. Therefore, prophylactic antibiotics are not recommended even in the setting of severe pancreatitis or sterile pancreatic necrosis. And next, the question of role of endoscopy in the setting of biliary acute pancreatitis. We see that majority of the stones in the bile duct, they pass spontaneously without the requirement of an ERCP. And sometimes as the stone passes, it can cause edema in the ampullary region. So LFTs can be elevated even after the stone passes. And multiple studies have shown that there is no requirement for an ERCP procedure in the absence of cholangitis in an early ERCP. But if there is very high suspicion of a choledocholithiasis, we can consider doing ERCP prior to the cholecystectomy. And now with the secondary prevention in gallstone pancreatitis, so even after we remove the stone or if the stone passes in the setting of gallstone pancreatitis, there is still gallbladder filled with stones. And the risk of pancreatitis is around 17% in the next 6 months after one episode of biliary acute pancreatitis. So therefore, cholecystectomy should be performed in all patients with gallstone pancreatitis. And this Poncho trial has shown that cholecystectomy can be safely performed during the same admission in mild acute pancreatitis. And in the setting of necrotizing pancreatitis, cholecystectomy can be delayed till inflammation subsides, which is around 6 weeks. Now with the management of complications. So Dr. Lee and other groups, they have shown this revised Atlanta classification, which showed that acute interstitial pancreatitis can result in acute fluid collections, which in 4 to 6 weeks can develop pseudocysts, and acute necrotizing pancreatitis can result in walled-off necrosis. So this can be sterile or infected. This can be pancreatic or extrapancreatic or both. And the management is different for each of those. And this is a pancreatic pseudocyst and a cross-sectional imaging showing a homogeneous collection. There is a well-defined wall around, and there is normal functioning pancreas around. And up to 16% of the patients develop pseudocysts, of which up to 57% can spontaneously resolve without the requirement of any intervention. And this is the evolution of an organized pancreatic necrosis. And as the days progress, we can see the pancreatic necrosis becoming more and more organized and a wall forming. And pancreatic necrosis have more debris within that. And on an MRI or an endoscopic ultrasound, we can better appreciate the amount of debris. And now with the management of pancreatic pseudocyst and necrosis, so the management options include surgical, by interventional radiology, or with endoscopy. But usually interventional radiology is an adjunct to either surgery or endoscopic approaches. And now comparing the pseudocyst drainage by endoscopy or surgery or interventional radiology, as Dr. Tucker was mentioning. So endoscopy has much lower, and compared to all of these, The technical success and clinical success is pretty high with all of those and no significant difference. But the risk of complications are different among these approaches. And endoscopy has much lower length of stay, much lower cost compared to surgery. And compared to percutaneous approaches, endoscopy again has lower length of stay and lower reintervention rate. And with the management of pancreatic necrosis, we can go through the endoscopy-based transgastric or transduodenal approach or through the CT-guided percutaneous drainages. And as Dr. Tankar was mentioning, so there are more recently lumen-opposing metal stents are used rather than plastic stents. And compared to plastic stents, lumen-opposing metal stents have similar treatment success rate, but they have much shorter time requirement for the procedure, but they have higher cost, and there is increased risk of bleeding and other complications associated with lumen-opposing metal stents when they are placed for a prolonged duration. So these should be used judiciously. And in the setting of large fluid collections, such as those over 12 centimeter or which extend to the flank, we might need a dual modality for approach. So we might need a combined transgastric approach with a percutaneous approach for the drains which are not accessible to the enteric system. And so this is the endoscopic pancreatic necrosectomy, and since Dr. Tucker has already mentioned, I'll skip the video here. But endoscopic necrosectomy is used to remove all the debris within the collection of the pancreatic necrosis. And this Panther trial from the Dutch pancreatitis study group has described a step-up approach for the management of pancreatic necrosis, especially infected pancreatic necrosis. So when there is an acute necrotic collection, and when there is no infection and when it turns into walled-off necrosis, many of the patients can be asymptomatic and do not require any intervention, where we can just observe. And when they have symptoms from the increase of the size, they would require intervention, and we can consider using percutaneous or endoscopic drainage, followed by endoscopic necrosectomy, and if these do not resolve, then a surgery. So a step-up approach should be considered. And when there is a suspected infection or confirmed infection in the pancreatic necrosis, an intervention is required. And rather than sending a patient to the surgery, so we should consider a percutaneous drainage or an endoscopic drainage among these patients, and even when there is no wall formed around the collection. And now that same study has showed that percutaneous drainage alone is sufficient in 35 to 40% of the patients, where wall-off necrosis is predominantly filled with liquid or minimal debris. And there was another study which did a meta-analysis of patients with pancreatic necrosis, and they showed that majority of these patients, up to 64%, can be managed conservatively and with the use of antibiotics in the setting of infected pancreatic necrosis. So the key concepts in the management of pancreatic necrosis is to define the collection, to define the extent of the collection, and delay as much as possible until we have a clear wall form around, and we can try to drain it first, and if that does not adequately control the symptoms or resolve the collection, then we should consider debriding it. And the disconnected pancreatic duct syndrome, as Dr. Tucker was also mentioning, so this can occur in the setting of pancreatic necrosis, especially involving the body, when there is still a functional tail that keeps producing the juices, and this resolution of the pancreatic necrosis is very difficult to manage. So in this setting, we can use a stent, a lumen-opposing metal stent, to remove the debris, and we would also place a plastic stent, which might be remained during the lifetime of the patient. And some other complications involving the pancreatitis. So there are splenic vein thrombosis, which involving the splenic vein, portal vein, or superior mesenteric vein, that can be seen in up to 24% of the patients, and majority resolve without any requirement of an anticoagulant. But anticoagulants are required when the clots extend to the portal vein or superior mesenteric vein. So this figure here demonstrates how the pancreas is so close to the splenic vein and to the portal vein. So with all the inflammation in the pancreas, there can be clots formed in this location. And there is one more complication, which is the pseudoaneurysm, which is present in up to 10% of the patients with pancreatic fluid collection. Therefore, we should be cautious when doing the drainage procedure of these collections and make sure that there is no pseudoaneurysm. And if there is a pseudoaneurysm, it's an absolute contraindication to drain the collection, till an arterial embolization is performed. And in summary, the key take-home points. So fluid resuscitation, so use lactated ringers in all patients, and you can be aggressive with a goal-directed therapy. And with enteral nutrition, route of administration does not matter. Earlier, the better, particularly in severe acute pancreatitis. And solid, low-fat, low-residue diet is better than liquid diet even to begin with. Do not discharge patients on anything less than a solid diet. There is very high risk of readmission on discharging patients on anything less than a solid diet. And there is no role of prophylactic antibiotics even in the setting of or in the sterile pancreatic necrosis or severe acute pancreatitis. And consider using non-opioid analgesics in the management of pain in acute pancreatitis. And there is no role of urgent ERCP in the absence of cholangitis. And cholecystectomy during same hospitalization is recommended for patients with mild gallstone pancreatitis. And percutaneous drain is the first step in suspected infected necrosis that is not organized and not surgery. And a step-up approach should be considered. And in the setting of splanchnic vein thrombosis, anticoagulants are indicated only when the clot extends to the portal vein, SMV, or there is a compromise of visceral perfusion. Thank you. And there are some additional resources.